This semester, SNAP will be hosting an interdisciplinary webinar series looking at how Medicare for All impacts the fields of dentistry, nursing, physician assistant, public health, and PhD medical research. Our organization is made up of health professional students from all fields, and as such, we would like to talk about how Medicare for All would impact our future patients in all aspects of healthcare. Last month, we focused on dentistry, and this evening, we'll be focusing on the nursing field. For those of you who are nursing students watching this, either live or in the future, you may be wondering, what is Students for National Health Program, or SNAP, as we call ourselves, and why should I get involved? Students for National Health Program is the student arm of Physicians for a National Health Program, or PNHP. PNHP is a single-issue organization advocating for a universal, comprehensive, single-payer national health program with more than 19,000 current members. We believe that a single, publicly funded, privately delivered universal healthcare system is necessary for us to provide high-quality care to all of our patients. Despite spending more than twice as much as the rest of the industrialized nations, the United States performs poorly in comparison on major health indicators such as life expectancy, infant mortality, and immunization. Moreover, the U.S. leaves 33 million people completely uninsured and millions more inadequately covered. Single-payer financing would save, on paper, more than $400 billion per year, enough to provide comprehensive coverage to everyone without paying any more than we already do. While the Affordable Care Act expanded Medicaid and mandated the purchase of private insurance, it still left nearly 25 million people uninsured. Today, that number is greater than 28 million people without insurance and climbing. The ACA had no concrete way to curb skyrocketing healthcare and administrative costs associated with a for-profit private health insurance industry. We can see a single-payer system in our lifetime, and we believe the time to act is now. Our presenters this evening are Patty Eakin, Mary Adamson, and Marty Harrison. Patty Eakin has been an RN since 1976. She worked at Temple University Hospital for 33 years, the last 17 years working in the ER. She's the past president of PASNAP, the Pennsylvania Association of Staff Nurses and Allied Professionals, a union of 8,500 bedside RNs and allied professionals. PASNAP has been a long-time supporter of Medicare for All. Mary Adamson has been a nurse for 25 years. She's worked in the ICU setting for most of her career. She currently works at Temple University Hospital in Philadelphia, Pennsylvania. Temple is located in one of the poorest neighborhoods in the country. She's a union leader and supports Medicare for All. Marty Harrison has been a nurse for 25 years, active in urban academic teaching hospitals. She's a member of PASNAP with Patty and Mary, and she works primarily in outpatient gastroenterology. So there will be an opportunity at the end of the presentation for any questions and commentary from the viewers, either via the microphone or the chat function that's in the control panel. It would be appreciated if everyone watching could mute their microphones until the end, but if you do have questions during the presentation, please type them into the chat bar in your GoToMeeting control panel, and I will moderate those questions throughout. This webinar is intended to create conversation, and it's a little more casual, so questions are encouraged. So without further ado, we'll go ahead and give it away to Patty, Mary, and Marty with Nurses on the Front Lines, Why We Need Medicare for All. And I do just want to ask, want to make sure that everyone watching can see the webcam of Patty, Mary, and Marty. If someone could just let me know in the chat section that is working. Okay, great. All right, I'm going to start. Thank you.
We're on?
Yes, you're on.
Okay. Thank you, Ashley. Good evening, everybody. My name's Patty Aiken. I'm a registered nurse, as Ashley said, and I spent most of my career at Temple University Hospital, most of it in the emergency room, but also doing oncology, and I worked on a med-surg floor that specialized in renal care. However, I am happy to say I'm currently retired, so I can talk about a lot of these problems in the past tense, unlike Mary and Marty, who are still working hard at the bedside every day. For all of us, our entire careers have been at the bedside as direct caregivers. So we see constantly how our patients suffer, and it becomes hard for nurses too, with all the problems at the bedside and all the problems with our healthcare system. We decided that the best way to sort of organize this talk that we're doing is to sort of ask some questions and then give some answers based on what we've seen with patients and what we think the problem is and how we think Medicare for All would help. But I think that Mary and Marty should, say what kind of nursing care they did and just say hello, and I'll start the questions.
Hi, I'm Mary Adamson, and I'm an ICU nurse. I work in a surgical trauma ICU. I've been a nurse for 25 years. And like the introduction, I work in a very poor hospital. We do a lot of blunt trauma. And so it's pretty busy. It's pretty intense. Marty?
I'm Marty Harrison. I currently work with outpatients in the GI suite. Like Ashley said, I have worked on med-surg in the ICU previous to that. So my experience is a little bit different, just that the outpatient world is a whole different world, but I still work in the hospital with Mary and right on top of the ER, where Patty used to work for such a long time.
And also, all three of us have been active in our union, PASNAP. We really like having the option to be in the union because we think it gives us a great opportunity to legally join together and raise our voices higher than we would be able to do as individuals. We spend a lot of time in our jobs and as union women, we spend a lot of time advocating for improved patient care in lots of ways. And I think that will come out as we talk about what we see and why we think Medicare for All is important. But so the first question we sort of worked up is, can you tell us, each of you, what kinds of things you face on the job? What do you see at work that would impact Medicare for All as a question?
So a lot, like we said, a lot of our patients are live in unbelievable poverty, but we are a level 1 trauma center, so we do get, car accidents and a lot of gunshot victims, but the disparity of resources for our patients is really obvious to me. I had a patient a few years ago. He was a freshman in college. He had a twin brother who was going to another university. He was going to a Philadelphia university. He was in a pretty severe car accident, dissected his spinal cord. He was quadriplegic. And he'd lived in a suburb of Philadelphia. His parents were lovely. They both worked. They were, living the American dream. Both of their children were starting out college. And they were at his bedside the entire time he was in the ICU. He left the ICU. He went to a beautiful, great rehab that we have here in Philadelphia. And, I didn't hear any more from him. But about a year later, I saw the family in the elevator, and they looked horrible. They were so downtrodden. They were so upset. And so later I got a chance to talk to the twin brother, and he said that because of the hospital bills, the family lost their home. They were living in a 1-bedroom apartment. He was sleeping on the parents' bed in the bedroom, the 1-bedroom, and they were sleeping on a sofa bed. And that's how they were dealing with the astronomical debt that they had acquired from his car accident. So that is something that Medicare for All would fix that problem. How about you, Marty?
Right, so like I said, I work with outpatients, and the way the lack of insurance reveals itself to us is a little bit differently. Lack of insurance or underinsurance, insurance that's too expensive to use, either because of the co-pays or the premiums, etc. So the way that we see that is people sort of getting on our schedule and then dropping off. Like Mary sees people that don't have insurance that are, in any case, they come to the ICU, they get care. That's not so much in outpatients. If someone doesn't have insurance, they really don't get back to me. They get stopped at one of the barriers in between scheduling the appointment and getting to me. And so people fall off the schedule, We get often like frantic calls, especially as the year goes on, from people who are trying desperately to get onto the schedule in that short amount of time in between, either when they've met their deductible and they don't want the procedure to go into the next year, because then their calendar will start at zero again and they'll be responsible for the whole deductible, $5,000, $7,000, whatever it is. Or they know that their insurance is going to either end or change at the end of the year. So we get these frantic calls from people who need to get on our schedule by a certain date, and we just can't always accommodate them. So it just it reveals itself a little bit differently between inpatients and outpatients.
But fundamentally, they're denied care because of some screwy health insurance program or lack of it. Whereas under Medicare for All, they would get what they needed, because it would be one insurance program and not all different kinds, where people have to like deal with deductibles and whether or not that treatment is covered. You were also saying earlier that you had that you had a lot of trouble like with patients who had get an infection, and let's tell that story there.
Yeah, so the physicians and the nurses that work in the clinical side with the physicians, what we call our side the procedure side. It's all clinics, but they're working on the office side, I should say. They spend a tremendous amount of time, going back and forth with insurance companies when an insurance company has denied care or a particular type of care or even a particular medicine that they say isn't on their formulary, in their list of medicines that they approve. And we have to go back and forth to find ones that they do. And there's some very common infections that GI patients have to get treated for, and we'll find them just, people returning over and over again, not being able to be cleared from these infections because and also, whether it's because or not, there's a correlation. I'm not going to say there's a cause, but they aren't getting the precise antibiotics that the physicians are ordering. They've had to go back and forth and figure out which ones will be covered rather than the ones that the physicians are trying to order for them.
So we have people who have nothing to do with medicine determining what the treatment should be. And when we do provide the treatment, sometimes the families go bankrupt.
Right. And you had another really telling story about sort of another patient who had a spinal cord injury, different kind, different outcome.
This is a very, they're both very sad stories, but there was a gentleman that came into our hospital and he was shot, and he became a quadriplegic, a paraplegic, and he went through a long stay with us, much longer than he really should have, because we couldn't find anybody to take him. None of the rehabs would accept the lack of insurance, that he didn't have insurance. And I think he was Medicaid. I'm not really sure about the insurance. I don't get into the weeds with it like Marty does, but we couldn't place him. So he got as much therapy as he could from us, and then he went home. And a couple of weeks later, he came back in an ambulance, and they brought him up to our ICU. He was so sick. He had lost so much weight, and he had pressure ulcers in places where I'd never seen pressure ulcers. His mouth, it was unbelievable. I mean, he had sores. Everything was caked and dry. And he lived in he was really poor, and there was nobody at home to take care of him. And the few family members that he had were working, and we spent weeks nursing this guy. We sent multiple surgeries, multiple nursing care, all kinds of money, all kinds of resources, and he died because he couldn't get the follow-up care that he needed because he didn't have the insurance.
Yeah.
And he was 23 years old.
Cool. And in that, if Medicare for All had been there, he would have been sent to a rehab center just like anybody else.
Just like the other gentleman.
Just like the other gentleman, and would have gotten the care that he needed. He could still be alive.
And the basic home care, someone to do
Yeah.
mouth care, someone to turn you, something to help you with just the daily needs.
So what I saw lots of awful things in the emergency room where I worked. There's lots of trauma, and lots of everything really. It was also the place for a lot of people to get primary care because under the current dysfunctional system, lots of people cannot afford to have primary care. And as everybody watching probably knows, primary care is what you need in order to prevent having to spend a lot of money and also having a lot of suffering at the other end. So we would see patients come in with all kinds of illnesses that were now going to be very expensive to treat and might leave people with lasting sort of decreased quality of life because of chronic illness. And the one case that I saw that has always haunted me was there's this man who came in. He was 35 and he worked as an auto mechanic, and he didn't feel well and he had a headache, but he had no health insurance. So the first thing I did was check his blood pressure, and his blood pressure was 260 over 140, which is one of the highest blood pressures I had ever seen. And of course, that explained the headache, you would think, of course, and it also explained why he didn't feel very well. So the next thing we did was we checked his blood, and as you can imagine, the blood work showed that his kidneys were really badly damaged. So here was a guy in the prime of his life, in the prime of his like earning his living, working for a place that had no health insurance, and now he was going to be on dialysis for the rest of his life. If he'd been able to get primary care, if primary care were available with some blood pressure medicine, he you can predict almost everybody can have their high blood pressure treated, and he didn't have any of that. So here he was in the hospital, and now he was getting very expensive. He was about to get very expensive dialysis treatment, which would go on for the rest of his life. And of course, his life expectancy is cut short by having to be on dialysis, but it's also extremely expensive. And it is paid, but it is kind of like a Medicare for all thing, because dialysis is so expensive, everybody who needs it gets it via the government, which pays for it. So they're paying, I don't know how many millions to have him on dialysis for the rest of his life. They probably could have supported an entire physician's outpatient clinic with lots of doctors and treated hundreds of patients and prevented people from getting, from having hypertension so severe that he needed dialysis. It's so wrong that anybody has to have that kind of suffering for lack of just basic routine health care. And one of the beauties of Medicare for All is that because everybody is in, and the care, everybody is in the insurance pool, everybody is covered, and primary care is emphasized because right now, primary care physicians or general practitioners internal medicine doctors tend to not get paid as much as specialty doctors. And so there's aren't enough of them. And, I think having Medicare for All, it would be really helpful. The system is very, very inefficient. Marty, you were saying something about how it is inefficient and expensive, but what were you saying about the physician versus billers?
Right. The statistic that we saw was that for every 10 physicians practicing, there's nearly 7 people employed in billing in some way, shape, or form. And Medicare for All would obviously diminish greatly the number of people that were needed to be employed in billing, and those people could be employed at the bedside where we need them. We need more staff. to adequately take care of our patients. We fight about that with the hospitals all the time. Staffing, staffing, staffing. Right?
What are some examples of bad staffing and what that's done for you? Mary.
So, where I work in the intensive care unit, things change all the time. It's a very dynamic flow. And a patient could be doing fine on the day shift, but night shift comes, they get septic, their blood pressure starts to tank, or we have to put them on multiple pressors. Sometimes we have to put them on a balloon pump, or they might go into kidney failure. We need to put them on CVVHD. So we need an extra nurse, and it's so hard for us to pull any extra staff, to get any extra staff when we need them on the floors, because so much of the cost of healthcare is going for all these, other things. So we really think that in a Medicare for All situation, there would be so much more emphasis and so much more resources dedicated to the actual care of patients and not the coverage of patients, because that's what everybody likes to talk about. They like to say, well, everybody's covered now, right? There's the ACA, everybody's covered. We see that everybody's not covered, and the health insurance objective is to not pay. So in a situation where, everything is paid for at the same rate for every person, we really believe that so many more dollars that would be freed up could be used at the bedside to provide more nurses, more patient care assistants, all the things that make a hospital run, all the things that make the answer to the call bell quicker.
Yeah, we know that Medicare or private health insurance is extremely wasteful. Like the overhead for Medicare is only 2%, whereas for private insurance, it's about an average, they say, of 13%. So that's like 11 cents, 11% of every dollar right off the top is wasted. And there's so much that could be spent on. We know from being leaders in our union and interfacing with nurses from all around the country, we know that the number one issue for bedside nurses is staffing. That there just, aren't enough nurses at the bedside to do it safely. And then, so there I am, like wishing there was just like one more nurse to help with this care. And I think of the high executive compensation of all of these owners, all these for-profit guys who are sucking patient care dollars right out of the system to pay themselves. What, Mary, did you say that statistic was?
Well, I think the highest paid insurance CEO is at $67 million, but a lot of them make, like, the average is around $15 million. And just to put that into perspective, that's like $40,000 an hour. Now, I'm a good nurse. I know I'm not worth $40,000 an hour. I'm always fighting for a fair wage, but I mean, come on. It's insane. It's insane. And a lot of, do you want to talk about the employer part of that?
I was getting to that next, okay. But so you can,
One of the things that we noticed so much, even as nurses, but all people, the objective to, or the opposition to Medicare for All is people love their employer-sponsored insurance. And I don't know if any of you have Blue Cross or Blue Shield or Aetna or any of the other ones. It's great when you call them and ask them why they're not paying for your MRI. It's always a good, experience.
Lovely conversation.
Lovely conversation.
14 hours.
Yeah. But one of the things that we think would change is that people would be free to do what they want in terms of work. If somebody who's worked for a company 30 years really has a great idea and wants to start his own small business, he stays where he's at because of the health coverage. He has a couple kids now, he can't do that. It happens all the time. People are tied to their job because of the insurance.
And FMLA only lasts 3 months. So there's nothing to prevent you from losing your health insurance anyway. Say you get breast cancer, that treatment can be way longer than 3 months. And so you can end up with a disease, with an illness that's long-term or chronic, and then you lose your job. And that's what gets you the insurance in the first place. I think that's kind of the definition of insanity. It really is, it's irrational, and it's completely unfair. There is no way, there's no other country, no other industrialized country on the planet, as far as I know, who basically, unless you're on Medicare or Medicaid, that demands that you have to stay at a job, or that if you lose your job, people lose jobs for all kinds of reasons. Companies close. But, you know, I had a friend who got sick and lost, you know, she had to get a lot of treatment. She ended up losing her job. And then she had no job and she was sick.
And she had no insurance.
And she had no insurance for a while. I mean, until they signed her up for Medicaid. And this was a woman who was very proud. She had worked all of her life and she was facing cancer without health insurance. After, so it really doesn't make sense that people have to be tied to their health insurance on the job. Besides which, as time's gone on and as the wages of workers stay flat, and even as unionization has gone down, the number of people who are insured on the job has decreased. And in addition to that, companies that even offer health insurance, because some of them do, because they apparently they feel it helps them retain employees. They're increasing the premiums. They're switching to all kinds of programs that include lots more co-pays, higher premiums, or these huge deductibles of $5,000 and $10,000 a year.
So if you make $50,000 a year and your deductible is $9,000, you virtually don't have insurance. Like, because you know, if you're a 30-year-old that may need, like, say you break your ankle running and you want to get surgery, you have to get surgery and they fix it and you get a cast and you're in a cast for a few months, none of that will be covered because your deductible is too high.
I do have a comment from one of the viewers. Jill did say the discussion about your health insurance being tied to your job and therefore kind of holding you hostage is so important, in all caps, and something I wish more people would recognize in this argument, which I personally agree with. I think that is such a compelling argument, and it's not, I feel like it's not stressed enough that some people are literally tied to their jobs because of the insurance that they have to get through their employer.
Yeah, good point. I mean, I think, and in this country, there's this sort of worship of small business. You know, small business makes the world go round. Small business holds up everything. Some of that is really not true. Some of that is myth. On the other hand, there are a lot of small businesses, and lots of people have lots of good ideas, and there's lots of small businesses needed. But many of them couldn't begin. You couldn't begin to like try to have a small business and pay health insurance to their employees or themselves.
Right.
You know,
Right.
It's really, I appreciate what the person wrote, because it really is a big nasty problem.
As union activists, we also see how having health insurance through your job is like a threat that the bosses, a control mechanism that the employers can hold over you. So people are reluctant to take the risk of going on strike, maybe leaving, losing their insurance for a period of time. It keeps people very, like, what do you want to say, obedient or
Fearful.
Yeah,
Fearful.
yes, very fearful, when they should be fighting for better wages, better conditions, a predictable schedule, time off, and paid time off, paid sick time, so they don't have to go to work sick. That's craziness.
One of the other things we wanted to talk about was the question of healthcare disparities. I mean, we sort of see that a lot of hospitals, there's, like sort of the question becomes, why are some hospitals seem to be, have lots of resources and lots of money and others are struggling. And it seems to me, it just seems unfair that a hospital, that there should even be such a thing as a safety net hospital where, the hospital's the place of last resort. And a lot of, because those hospitals aren't getting the same reimbursements because they, quote, don't have a good payer mix, where they don't have a lot of people with private insurance, which pays more than Medicare, and certainly pays more than Medicaid. So like a hospital where we happen to work, where, by the way, if you are born in the census tract around our hospital, your life expectancy is 20 years less than somebody born in another part, in a few other parts of the city. So there's a lot of disparities, and that's played out in healthcare. Under Medicare for All, as I understand it, hospitals would get the resources they need, not the resources they can scratch for. That based on the needs of the patients. And so you have some hospitals. We have one hospital in the city where they had so much extra money, they bought themselves a train station. They put a ton of money into a train station, got the whole train station named after them. It isn't right that money is put into those kinds of things, and insurance companies, they put it into advertising, and they just waste all these dollars. And yet we look at other hospitals where, the resources are smaller, and it's the patients that suffer. If you don't have enough resources, you don't.
So basically what the current system does is it provides the least to the people that need the most.
And we fight every day at the bedside for the staffing, the equipment, the supplies that our patients need in that moment at the bedside. And it's a fight about money always with the hospital, with the administrators. But we see the to take that fight beyond the bedside, outside the walls of the hospital, so that our patients are taken care of after they leave us. And Medicare for All is what every patient needs, so that they can continue to get the care once they leave outside of the hospital.
I think as nurses, we are always told you are patient advocates, and I think almost all of us went into nursing because we wanted to be in a profession that was helpful, helping people. And it is a great profession. We have a wonderful opportunity to really do something that is extremely valuable. I mean, we think healthcare is valuable for everybody. So actually, we think healthcare is a human right.
Yes.
And I think most people who support Medicare for All also come at it from there should not be these giant profits made in healthcare. The money shouldn't be sucked out and go into big buildings and big executive compensation and Wall Street dividends when we have people who are suffering everywhere. And that's what we see every day at work.
And it doesn't have to be that way. The resources are there.
Is this the richest country on the planet?
In the history of the planet.
In the history of the planet.
We just need to redirect the resources to care, not coverage.
So we understand that, that Medicare for All means that basically the same amount of money is redirected, and they say for 95% of the families, the money would be less. But in return, those 29 million people Ashley mentioned in the beginning would be covered. Everybody would be covered. So we think that's really important.
And it's going to be a fight. Make no mistake about it. But we think that nurses are strategically placed to be a really important part of that fight, because we are just uncompromised advocates for the patients. We get paid by the hospital. We don't get any reimbursements from insurance companies. So we have no financial connections to them. And as organized nurses in a union, we also have that organizational way to fight for Medicare for all, not just as individuals, but together as union members.
You know, and they say that when they say that people are attached to their health insurance plan, we really were talking about this earlier. We really think it's more like they're attached to the security of knowing this is what they get and this is what they pay. And I think a lot of misconception comes from, you know, the opposition says, oh, it's going to raise your taxes. Well, there will be taxes, but there will be no more insurance premiums, no more, no more co-pays, no more deductibles. And most people, like I said before, I don't want to keep repeating myself, but most people will save money. And we have this situation where, you know, people are kind of playing Russian roulette with their, with their health.
There is one group of people that will not make as much money, and that would be my favorite, the insurance CEOs.
Right.
They will take a hit.
We think they should go to nursing school. We're pretty sure that they've never done anything terribly useful in actually caring for a patient. And so there's a shortage of nurses coming, and actually that does point out to one other thing. I mean, the system that we have currently is so wasteful and so inefficient, and we didn't mention this before, but we are aware that these hospitals have hundreds and hundreds of people focused on billing, trying to fight with insurance companies for every test, and there are nurses who actually train doctors on how to write their notes and how to type their notes into. Now we have electronic systems, how to type them in so that they get the money. So it's a constant game trying to get the insurance companies to pay because they don't want to. Mm-hmm. So I just kind of think that is most of what we wanted to talk about. Was there anything else that you felt needed to be?
One of the other problems sometimes people say is what happens to all the people who lose their jobs? If you get rid of the insurance companies, what happens to all those people? And if everyone were insured and everyone were getting the care that they need, we would need so many more people at the bedside. We would need bedside caregivers, and many of the people employed by the insurance companies already are registered nurses, and there aren't that many barriers to them coming back. It would just have to be a job that they wanted. We would have to have sufficient staffing in the hospitals so that you weren't going home in tears every night because you were so frustrated about not being able to give the care that you wanted to give. So I think that we could just easily, or maybe not so easily, it would still be a big job, but there's a place for that. Those people aren't necessarily just going to be unemployed. We need to retrain them and get them back up to speed, but it's not nearly the impossible task that the opponents of Medicare for All would make it out to be.
And I think the legislation that's proposed accounts for that and has plenty of training and attention to that, because we certainly, it would be a dislocation. We don't want anybody to again lose their job. Only thing you can say is that if they lost their job, they wouldn't lose their health insurance. That's about all their health care. Yeah, right. It's about all.
And, it really would be, there's a lot of changes that need to be made, across our economy. And this is just one of them where it would be a redirection of labor. We would be moving away from the payer model toward the care for all model. That's what we need. We need care for all. And there will be jobs for that.
Yeah. And people need to, I think one of the, like Patty was talking about, people are so happy with the insurance that they have. But I think it's also too, people just can't even imagine how great Medicare for All would be. We need to lift people's sights and make people more hopeful and can imagine something that's much better than we have now. People have been so accustomed to like everything being a fight and everything being difficult and everything like you have to be able to pay for everything rather than just no, I'm a person, I have these basic needs and I have human rights and I need my basic needs cared for.
I can cut you off. No, you did not cut. You did not cut me off. There was really only one last thing I wanted to mention, and we can go to questions. But I think as always, it's in this country. What we've been reading and seeing, and what we see at work is that it's Black and brown people who bear the brunt of it. There are, the mortality rate tends to be worse for them. There was a study I was just reading the other day in the New York Times about how African American patients are treated differently. They tend to get less treatment. They tend to have worse outcomes, and we need to address that. I don't know that Medicare for All specifically addresses that, but to the extent that it equalizes out resources, I think there's a chance that that can be addressed in a more equitable way. It just doesn't seem fair to me that if you're African American, you're much more likely to have pregnancy complications than you are if you're white. That all those issues need to also be addressed. And I think in the context where you take out the insane sort of profit-driven system and you're looking at what do people need, not how much money can a health insurance company get, then you have a chance to address those problems. Probably we could go on endlessly, so let me stop us now. I'm sitting too far away from the computer to see the questions, so Ashley, do you want to?
Definitely. Does anyone watching live have any questions? You can either use your microphone or use the chat section in the control panel. And while we're waiting, go ahead. If you do have questions, go ahead and put in the chat section. I have a couple of questions of my own. And it's really two questions kind of bundled into one, but were any of you involved with advocacy when you were a nursing student? And if so, how? And how do you think that, how do students play into this fight for Medicare for all? And where are we most useful in that?
Well,
It was so long ago.
Yeah,
I hardly remember.
yeah. Well, that was 1976 that I graduated. Yeah. It was beaten over our heads that we were supposed to be advocates, but it was all individual. You at the bedside must be the best nurse you possibly can. And they never wanted us to look at systems and see how you could advocate to change the whole friggin' stupid system. It was all about just you as the individual. I didn't want us doing anything together like that. I didn't see anything when I was in school. But what can you guys do? I mean, I guess what we all have to do is be explaining, writing letters, lobbying, being out there in the public and pushing this. Obviously, it's got a lot more supporters than it had a few years ago before Bernie ran for president.
Right. That's what I was just going to say. That something super important that students do now is they bring that youthful exuberance.
Yeah.
But also the effect that Bernie has had and the Bernie campaign have had and the support for social democratic policies, not just Medicare for all, but the Green New Deal, free college, free public college, et cetera, bring that, just the way that those policies have become mainstream, to bring that to the fight, that this is duh, so day before yesterday, why didn't you all figure out this ahead of time? Here we are, and not being caught up in any of the ridiculous arguments that we've heard for so long. Oh, it's personal responsibility, or everyone needs to, pay their fair share, et cetera, et cetera. We know that people are working hard and not getting a fair shake.
Yeah, and I think it's really important to get involved with things like SNAP or any kind of programs in your area. You don't realize how desperately we need young people for all kinds of reasons, primarily like hooking up these webcams. I mean, there's really, I don't know, I don't mean it like a joke like that, but there's really a whole knowledge base that you bring to the table when we're fighting for these things that we don't have, and we need you for that. So, it's really important to have people engaged on these life-altering system changes that we care about from across the spectrum of age, because, it affects us all, and we all offer different things that make it possible to win.
Yeah, I think those are all really great answers, and it actually just made me think of a quote that I wrote down from the SNAP Summit a few weeks back. Wendy Cord is a student in SNAP, and she was speaking on an intersectionality panel about the single payer movement, and what she said was, everyone's advocacy is their own experience. Know what advocacy fits you, explore it, and then do it all the time. So I feel it is really relevant for students because, we're so busy with studying and everything, but whatever we can do, as you're saying, even helping with technology issues, or just whatever we can do to contribute to the movement, I think is helpful. And I'm glad that was reinforced with your answers. So I do have a couple of questions from the viewers. One, I think these are kind of related. The first one is, what would be your top 2 talking points to discuss with people who don't share this point of view? And then I'll go ahead and read the second one because it is very similar. Jake said, I'm from Nebraska, and as you can imagine, outside my age cohort, there's very little support for Medicare for All. I'm assuming in his area. What's a way I can talk to patients without seeming preachy? Or perhaps what have you found to be the best talking points in the Gen X and Boomer populations? I feel like those are kind of related to one another.
I think one of the most important ways for people to understand why we're fighting for this is because the system we have now is really, really broken. It's really sick. So, there's how many? 30 million people that are not covered right now. There's, the statistics are staggering. There's so many broken things, and it's such a patchwork quilt of coverage that we need to simplify it like all other countries, and make the most out of the money that's spent on healthcare.
I read something the other day about just how people's brains work, is that we're much more empathetic to an individual that's having a problem than we are to a huge group of people having a problem. For some reason, we get it backwards in our heads, and we think that one person's problem is more important than, whatever the thousands of people who are now in this cyclone in Mozambique or whatever it is. But that I think we can use that in some ways. What we found even in our own healthcare advocacy is that it's the stories actually sometimes that get through to people. And if you start with the story and then draw the lesson out, so even as students, you're going to be seeing patients that are in all sorts of illogical situations because of the lack of logic in the system, that the system is compelling behavior that is not good for anyone involved, right? No matter what it is. And to start with the story and then draw out the lesson in terms of Medicare for All, because there's no logical there's really no logical argument against it. There's no mathematical argument against it. It's going to cost less overall, and everyone's going to get more out of it, right? The U.S. spends more, does not get the best outcomes. What do we need to fix that? And Medicare for All is a huge step forward. And I think even if it won't fix everything, because that's another argument people make sometimes, right? It doesn't do anything about, well, it doesn't do enough about cost, et cetera, et cetera. But we can't even see the solutions to those problems until we at least take this big step forward, get everyone covered, and then we can maybe focus in on some of the smaller or other problems that are just would be difficult to even isolate and think of a plan to deal with right now.
It's important to help people realize that Medicare for All is not the government providing the health care. It's the government providing the coverage. All the doctors are still there, all the nurses are still there, all the hospitals are still there. That doesn't change. It just takes away the middleman, the insurance guy.
Yeah.
I think they said it. I don't have anything new to add to that.
I think that was such a good point, Mary, too. Yeah. I lost my train of thought. But anyway, does anyone else have any questions from the audience? Oh, I know what I was going to say. Related to that, I think, too, that some of my I've been most successful talking, kind of like you said, Marty, too, about someone's personal experience with the healthcare system. Just starting with, do you like your health insurance coverage? And, well, I guess that's not really the best question. Asking more, do you like the way health insurance works right now? Most people will say no. And, that's kind of how you can start that conversation. With, how Jake kind of mentioned sounding preachy with patients. I think talking about it on a more personal level, even with their own experience or in people that they know that have had trouble with insurance and the healthcare system, I think getting down to that personal level is very helpful with those conversations, because I definitely understand being in Louisiana too. It's hard sometimes. But all right, if there aren't any more questions from the audience, we'll go ahead and wrap up. If anyone who is watching, again, either live or later when we post this onto YouTube, if you're interested in learning more about PNHP or SNAP, please visit student.pnhp.org or just search Students for National Health Program. There you'll find an opportunity to join PNHP, which is free for all students, and receive emails and regular updates from SNAP. You'll also find a list of current chapters to see if your school has an established chapter. You'll find resources on ways you can learn more about single-payer healthcare and Medicare for All, including access to our previous webinars and single-payer 101 talk under chapter resources and webinar series. Our next webinar will be focusing on the physician assistance field, and it will be held on Wednesday, April 17th in the evening, time to be announced. So thank you everyone so much for tuning in. I think this has been such a fantastic conversation, and I'm so happy that we were able to hear from the three of you.
Thank you for inviting.
We have one more question from the audience. Jake also said, my girlfriend's a cardiac ICU nurse and very much supports Medicare for All. My understanding from her is that most major nursing organizations are progressive and often pro-Medicare for All. Are there any particular organizations that you suggest her to get involved in?
Where is she working?
I believe Nebraska.
Nebraska.
Yeah.
Well, she could try. Yeah, National Nurses United, NNU. I don't know if they have anything happening in Nebraska per se. That'd be a great place to start, because they really are, of all the nurses organizations, they're the biggest, and they lead on the question of Medicare for All.
Mm-hmm. You can follow them on Facebook and get updates all the time from them. They have a good social media presence on all the platforms.
In fact, I swear I got an email from them
while we were sitting here.
Yeah, it's about some work they're doing nationally. They are organizing a lot of national Medicare for All call-ins and state campaigns and,
That's National Nurses United,
yeah.
NNU.
Yep. Yep, I got an email yesterday from them. So, that would be a great place to get connected.
Yeah, and they also do a lot of coalition building. I know they've done work with like DSA chapters. They just had their recent big it was a big like week-long event pushing for the new Medicare for All bill in the House, Representative Jayapal's bill. We did a joint event with them here in New Orleans too, NNU, DSA, and SNAP here. So,
Michael Leidy.
wait, say that again.
Michael Leidy.
Who's that?
He's
Never mind.
never mind.
Sorry. An NNU staff person that speaks on Medicare for All sometimes.
Oh, okay. Well, that's a very good resource for anyone who can look them up. All right. If there are no more questions, I guess we'll go ahead and wrap it up after I'd already said my ending spiel. Thank you so much, Patty, Marty, and Mary. This has been a fantastic conversation. And we'll keep fighting for Medicare for all. Thank you so much, everyone. Have a good night.
All right,
Thank you.
Ashley. Thank
Good
you
night.
very much. Good night, everybody.